So I'm Daniel Lee. I am a clinical professor of medicine here at the UCSD Owen Clinic. And I was just mentioning that my area of specialty is in the management of metabolic complications of antiretroviral therapy. I have my own subspecialty lipid and lipodystrophy clinic managing these metabolic complications now for over 20 plus years. I kind of love the stuff that I'm going to be talking about today. So I was inspired to talk about this subject today in regards to, should metabolic and cardiovascular consequences of integrase inhibitors impact our first-line antiretroviral choice. And it was really because I'd read a few papers recently that had come across my email that was, I thought, a bit provocative. And I just got back from Montreal from the IAS conference, and there were some other abstracts that were actually pretty interesting. And I'd like to be provocative. So let's see what you think. I'm here not to necessarily convince you or sway your decision. In fact, we're actually interested in seeing what you think about it. So let's go ahead and start. Jill's going to be monitoring the chat pod, so she will interrupt me if there's questions. I have this broken up into several sections, so we could also take. So we were not recording before this? Okay. Got it. Okay. All right. Start. Uh-oh. So now this doesn't work. You want to? Got it. Okay. Now we're working. All right. So I do have a few disclosures listed here. But our learning objectives is to review a few things. So we're going to talk about some of the recent weight gain data. I think some of the newer data in regards to hyperglycemia as well as diabetes in relation to integrase inhibitors. And then some newer data in regards to cardiovascular disease. I'm sure when you read the title, you were like, well, what is he talking about? What cardiovascular, what kinds of issues with diabetes and integrase inhibitors? And so that's kind of why we're talking today, because there is some newer data, and I'm curious to see what people think about whether or not that changes people's mind in terms of using integrase inhibitors. And then we'll talk a little bit about how to apply these to patient care. So I do have polls, so I think this would be interesting. So if you can pull up your phones and on pollev.com, and you can text or type AVRC SYSADMN 479. And so I'll read the question. In your own clinical experience or reading of the scientific literature, do you feel that integrase inhibitors cause weight gain? So if you do not, so there's a no, there is a yes, but rarely, approximately 0 to 25% of the time, yes occasionally, 26 to 50% of the time, yes frequently, 51 to 75% of the time, E, yes, very commonly, 76 to 100% of the time, or F, don't know, or if you're not a clinician or you want a cop-out answer, you can use F. So, but no one will know what you choose, and let's just see. So we are testing this out, and hopefully this will work. So far, no one has answered. So what?
That's a very complicated way to respond.
Okay. Well, we can forego that if you want.
Hey, Dan, I tried responding and it says that the poll isn't open.
Yes. Okay. So it said the poll was not open. Thank you. We can always forgo.
I'll say E. It doesn't have to be anonymous as far as I'm concerned.
Yes. Well, would you love to answer the question then? I'm open to discussion here.
Very common.
C. Okay. Okay. No worries. So Jill says C here, and some people say C, and I presume most people are probably going to say B or C. I suspect you're not necessarily seeing a ton very frequently or that commonly. And I think some people might answer even no if they are not necessarily. I think sometimes you see these weight gain issues and sometimes you don't. So I guess I just answered that question myself. I was going to ask the same question in regards to diabetes as to what you think. And maybe we'll just pull this audience in front of me here just to see if anyone wants to answer that, or either I will make Jill answer that question for me. Did I hear an answer? Oh, yeah. I think our poll is okay. Yep. Yes, that will work. Yeah, so probably, once again, I suspect this answer, people will probably say less than the previous answer, because I think we see more weight gain than certainly diabetes, but I will talk about that. And then my third question, which was the same thing, but asking about cardiovascular disease. And I suspect even more people will probably say less so because, to be honest, we really haven't heard anything about cardiovascular disease and integrase inhibitors.
It's odd. I hope people are putting things in the chat now because there were a bunch of messages and then, okay, good. Now people are just, okay. There was an A just now for the last one.
Thank you. So, so what's obviously we have had these integrase inhibitors for a little while now, and it really is the first line choice of antiretroviral therapy. It's in all of the guidelines, of course, right? And so people have done quite well, and there are many benefits of integrase inhibitors. Certainly higher barrier to resistance, good tolerability, once-a-day dosing. And then I have underlined, low perceived adverse events. And so I guess I'm going to try to add a few more potentially adverse events to your mind, so to speak. So there has been some more emerging new data suggesting maybe, certainly weight gain we'll talk more about, but hyperglycemia, diabetes perhaps, as well as cardiovascular disease. So this is really just an opportunity to provide some of that information to you. So of course, we're familiar with the various guidelines. This is the DHHS guideline, which basically shows that integrase inhibitors are the main agent of choice. And I will use my arrow here so everyone online can see. And this is not unusual, just like all the other guidelines that say integrase inhibitors are the first line choice. So let's talk a little bit about weight gain. And I know that many of you have seen some of the data, and there are now actually multiple studies that have actually suggested this relationship between integrase inhibitors and excessive weight gain. And that has been seen in both treatment naive as well as treatment experienced patients. The exact mechanism, however, is still kind of unclear, and there are a lot of different thoughts as to perhaps why. In part, I think there's definitely this, what we call return to health phenomenon, where people, let's say, who are untreated for HIV, get on antiretroviral therapy and gain some weight. And in part, it's because HIV perhaps speeds up your metabolism, and thus, when you take HIV meds, you slow your metabolism back to more normal, and that sometimes can lead to this kind of return to health weight gain that we see. some people theorized about the tolerability of integrase inhibitors, and perhaps it's better tolerated, so therefore people can eat more versus older regimens that maybe people had more issues from a GI standpoint, and perhaps that's part of it. There are also thoughts about perhaps integrase inhibitors maybe affecting things more at the gut level and maybe improving absorption and improving perhaps GI function. So the food that you eat, you maybe absorb better. There's been talk about that. Immune reconstitution's been talked about, as well as inflammation. And there are some studies I'm not showing here suggesting that even with integrase inhibitors, there may actually be a little bit more inflammation that actually happens, and whether or not that is perhaps causing some of this. I think the most interesting stuff maybe has to do with this idea about direct effects of integrase inhibitors on fat as well as fat differentiation. And I'll kind of sprinkle more of that discussion as we go along and talk about some of this data. Excuse me. So I think many of you are familiar with the ADVANCE study, and this was a study of treatment-naive individuals, open-label study. People were randomized to one of 3 arms. So in red, I know the writing's a bit small, but this is the dolutegravir TAF-FTC arm. The blue is dolutegravir TDF-FTC, and then the green arm is the efavirenz TDF-FTC. This study was in Africa, and so majority of the individuals were Black. There were quite a few females, about 60% female. Some of the interesting things, if you really look at this data a little bit closer, is that if you actually look at the weight of the men and the women here, the women actually weigh more than the men here. And then when you look at body mass index, the males also, no surprise, if they weigh a little less, their body mass index is also a little bit lower. And I think whenever people talk about this study, they don't really go into that level of depth, but I think it does make a difference, because I think for many of you, you're already aware that on the right here is that what we've seen is that women tend to gain much more fat than men. And that's kind of seen here on the right. But you do see that both arms, at least in the red, the dolutegravir TAF arm had the most weight gain, then followed by just the dolutegravir with TDF, and then lastly by the efavirenz and TDF. And so this gets into the question, well, why women? Why do women get more weight gain, perhaps? And I don't think that has been well described. I do remember from a prior study back in the early days where in the lipodystrophy days, we used to see that women, because they had more fat, then they were more susceptible to some of the fat accumulation issues with lipodystrophy, versus men who had less fat. They actually seem to have more of the lipoatrophy issues with lipodystrophy. And so I am curious as to whether or not this perhaps holds up and maybe explains why women are more susceptible to this weight gain that we see. And it's just because women tend to have more fat. And if you have integrase inhibitors that are now actually infiltrating directly into fat cells and perhaps making fat grow, then maybe that is why. And so just a theory, not proven, but I think it's plausible. There was another study by Paul Sachs, which looked at a pooled analysis of weight gain in 8 randomized controlled trials in treatment-naive patients. They're about over 5,000, greater than 10,000 person years. What we found was that some of the baseline demographics that were associated with weight gain included things like lower CD4 count, higher viral load. And those two kind of go along with this return to health phenomenon. So the lower your counts, the higher your viral load. When you do start antiretroviral therapy, there is more of this potential for return to health. But what was also found was female sex and then Black race. And so I've talked a little bit about at least female and weight gain in terms of why that perhaps might happen. In regards to Black race and I think also people of color, I think I wonder if part of that may kind of go along with some of the obesity trends that we see, certainly in the U.S. here, and that we do see, you know, disproportionately increased obesity rates in people of color. And that, once again, if you have more fat and integrase inhibitors get into fat, then maybe there's more dysregulation that then leads to the weight gain. Once again, not proven, but at least I think that's a theory that I'm kind of going with, at least for now. So, and what was found also in this data was that integrase inhibitors was also more associated with weight gain than compared to protease inhibitors or NNRTIs. And so the diagram on the right here shows weight gain here in these two, A and C, absolute weight in B and D. We'll just focus first of all in A, and what you can see here is that integrase inhibitors are in the red bar here, PIs in this blue, and then NNRTI is in this green. And what you can see is that definitely integrase inhibitors, probably after weeks 24 or so, start to spread out in terms of the lines, suggesting higher amounts of weight increases compared to the PI and NNRTI arms. If you look below that in C, what you see is that bictegravir in red and dolutegravir in blue tend to have the highest weight gains in comparison to the green one, which is elvitegravir boosted with cobicistat. So this is also still from the same data, looking at this issue of sex and race. And once again, females on the left here have more weight gain than men here on the in blue, and in the middle here, the blacks had also more weight gain than non-blacks. And then if you look at both sex and race, you see that the Black females had the highest weight gain, followed by Black men, which was greater than the other groups. And so I think this is just kind of the initial data I think we've seen recently. This was an interesting study that was presented at ID Week last year, looking at factors associated with weight gain. This was a study that was performed at Ohio State at their infectious disease clinic. The study period was from 2014 to 2019. And just some of the baseline characteristics were notable, primarily male population, primarily white. The mean weight was about 85 kilograms with a BMI of 27.6, well-controlled HIV, CD4 count of 714 and 98% undetectable. You can take a look at their antiretroviral regimen, their backbone here. Keep in mind, this is 2014 to 2019. The main backbone that was seen here, interestingly, was a Bacavir 3TC, and about 20% was TAF FTC. Oh, sorry, I take it back. Majority was TDF FTC at about 50%. So keep in mind, this was done back in 2014. In terms of integrase inhibitors, majority was dolutegravir, and this is probably before bictegravir came out, and then still quite a bit, 30% of efavirenz use. The reason I'm kind of talking about these baseline characteristics is I think it is very important when you're looking at these studies to know really who are you looking at, because I think that absolutely helps in interpreting the data. And what was interesting in this study was that if you look at here in red, what were the factors independently associated with an odds of more than 5 kilograms of weight gain? So 5 kilograms is about 12 pounds or so. What you see is TAF FTC had the highest adjusted odds ratio, but also dolutegravir as well as any integrase inhibitor were also factors associated. Interestingly, there was this continuing the same antiretroviral therapy was also a factor. I'm not sure how to make sense of that, but it does make me think about the cumulative effects of antiretroviral therapy over time. And I think that while we sometimes talk about regimens being very safe and neutral, I think we do also have to think about long-term complications in regards to cumulative effects over time. If you look, however, at protective factors, this was probably the only study that I've seen that actually have shown that dieting actually helps with this weight gain issue. So I think that this is still something that we should advise our patients, is that diet and exercise do help in this. And this perhaps is reassuring that at least that can help, versus in the past, people who have lipodystrophy, maybe it's been a little bit challenging because people do diet and exercise, and that was not able to help too much in regards to the weight gain and the fat changes. But as you can also see here, male gender was actually protective here. And then even other regimens, so TDF, FTC, was felt to be protective, as well as the other classes of antiretroviral therapy, so protease inhibitors as well as non-nucleosides. So I think it's kind of interesting data and something new perhaps you may not have seen. So I wanted to shift a little bit to talk about the Denver Health weight gain study. And this is another study that looked retrospectively at patients starting antiretroviral therapy from 2005 to 2019. You can see the inclusion and exclusion criteria here. What they assessed was looking at weight at baseline, and then they looked at different time periods, what's considered early weight between first 4 to 12 weeks, then around 1 year, and then around 2 years. And keep in mind, this is a clinic, so it's not like people had to do labs specifically at specific times. It's kind of a convenience sample. And what we'll talk a little bit about in a sec is this definition of excessive weight gain. And that's defined as the top 20% of weight gainers. And we'll come back to this in a quick second. The main outcome measure was looking at the percent weight gain at 2 years from baseline. So just some of the baseline characteristics. Again, I've kind of highlighted a few notable things. The median age was 36. There were only about 9% female, so not a lot. This was primarily more of a BIPOC population, so Black, Indigenous, people of color. CD4 count at this is naive people, so 288. Viral load median was 63,000. And the median weight, at least at the start, was 163 pounds with a normal BMI. In terms of what regimens these people were started on, so from an integrase inhibitor class, dolutegravir was the most common one. For non-nukes, there was still efavirenz, so keep in mind this is still including probably old tripla times. And then with protease inhibitors, majority was more on atazanavir than darunavir. And then the popular nucleoside was TDF, at least at that time. And so if we look at what their median weight was 163. Interestingly, at 2 months, the weight actually did not change, was still 163. There is this little asterisk here, basically suggesting that the N here was a little bit lower at 217. And I'll come back to this because I suspect maybe if there were more people, maybe there may have been a difference, because when I'm going to show you on the next slide, there is actually a difference at 2 months. But the median weight at a year was 170, so up about 7 pounds. And then at 2 years, another 3 pounds of weight gain. And so if you look from 163 to 173, this was about a 4% weight gain increase over the 2 years. The body mass index then increased from 23.7, so from normal to just slightly over 25. If you look at the top weight gainers, as I said, the top 20%, they gained about 13%. So 13% of 163 ends up being somewhere around 20, 22 pounds, which is actually pretty significant. So another point to make here is that while we are presenting data, this is population data, what we really want to pay attention is the patient in front of us, who may be some of these outliers, so to speak. Okay. And so this is an interesting, I think, slide. And so let's focus first on the bars, which represent the number of patients. And this slide is looking at weight gain at 2 months. So let me help you with this. So if you compared your weight from baseline and then at 2 months, and if you did not have any weight gain, you were included in this bar here. So there was about maybe 20 plus patients that had no weight gain here. But as you can see, if you look at this entire distribution, it does kind of skew more towards the right, suggesting that in general, people do tend to gain weight here. And so it's up to 1%, 2, 3, all the way up to greater than 15%. And so if you look at month 2, then there's actually about 11 people who've had greater than 15% weight gain, which is really significant, right, in 2 months. And this line that you see are the people that are considered to have, at the end of 2 years, they're the top 20% gainers of weight. So what this is suggesting is, so let's just take the very end here of this orange line, it says 89%. So what this is saying is that of the 11 people here that gained 15% of weight in the first 2 months, 10 of those 11 people, or 89%, still finished by the end of 2 years, finished in the top 20% of gaining weight. So bottom line is that it looks like perhaps early weight gain was correlated with perhaps later weight gain, and perhaps maybe we can use this 2 months or 3 months as perhaps a surrogate marker to predict people that maybe might be at risk for of higher weight gain later. And so I think this is interesting because from a clinical practice, the question sometimes becomes, well, how do we know if they're going to be one of these people that's going to gain a ton of weight? Well, maybe now we have something to look at. Maybe we do need to look at the weight at, month 2 or 3. Maybe that might suggest to us, maybe we change meds at that time. I don't know. So something to put out there. This is still the same study, but looking at the multivariate analysis in terms of factors that are associated with this excess weight gain at 2 years. Bottom line, baseline viral load, which goes along with the return to health phenomenon. Female here also almost statistically significant. NNRTIs were a little bit protective. What was not on the slide was integrase inhibitors, but I did find it. And interestingly, at least in this study, integrase inhibitors was not necessarily a factor predictive of this weight gain, which is a little bit odd, but different. But I think the numbers are somewhat low, and perhaps we also we need a little bit more data and time. Question.
Hear me?
Yes.
Yeah. So, do any of these studies have any baseline data for HIV negative populations as far as like the standard weight gain for an average person?
Yeah, no, not that I know of. And I think that's a great point. And so a lot of these are not necessarily controlled studies. And so I think the point you're getting to is that probably in an HIV negative population, you probably would also see some amount of weight gain with time. And I think if you look at non-HIV populations, there is probably like a kilogram or so. And so maybe this is comparable to just the general public. I think the outliers are definitely different, but I think your point is well taken. I think, unfortunately, a lot of these studies do not have an HIV negative control arm. Yeah. So and the other thing too is I think the issue, some of these studies are done during the time of COVID. And so there's obviously weight gain with COVID that we've seen, less activity, et cetera. So I think you have to take that into account as well. So the conclusions from this study was that early weight gain was moderately correlated with excess weight gain, et cetera. So, and that perhaps, if you're seeing these people with weight gain, and maybe candidates for early intervention, especially I think at the 2-month mark. It's absolutely something we can do. What I wanted to really show you was that there was a switch study finally that has been presented in terms of switching people off an integrase inhibitor to something else to see if whether or not that helps with weight gain. And so this is a study that was presented at IAS looking at that exact issue. And so people were switched to either, so everyone started an integrase inhibitor, and then they were switched to either a protease inhibitor-based regimen, or they were switched to a different integrase inhibitor. This was a retrospective longitudinal cohort study looking at EMR data. So this is not something that was pre-planned, et cetera, but just taking a look at a database. And so the inclusion criteria, the neat thing about this study was that they wanted to choose a higher risk population. So they included anyone who was female, anyone who was Black or Hispanic, because those were the risk factors, at least that were seen in previous studies. So what they identified was about 97,000 individuals in this kind of high risk category. But then when they looked to see specifically these two groups, the PI cohort, which are people who were started on an integrase inhibitor and then later switched to a protease inhibitor, either darunavir or atazanavir. There were really only 46 people. In terms of people who are on an integrase inhibitor and then switched to a different integrase inhibitor, that was 310. So the numbers were actually pretty small to start with, but with the magic of statistics, as you can see, 41 and 310, they're kind of unbalanced groups. And so to balance them, there is a statistical method called inverse probability of treatment weights, which I cannot explain, so please do not ask me. But magically, you balance the groups, and from there, it changes the sample size changes to 153 in the people in the PI cohort, and then 203 in the INSTI cohort. And so majority of those people in the PI cohort were switched to darunavir. For those in the integrase inhibitor, there was kind of 50% were switched to bictegravir, 40% were switched to dolutegravir. And then there was still quite a bit of TAF, 50% and 65%. So, and just of note, I'm not really addressing TAF related weight gain in this talk. So once again, looking at demographics, and I'll kind of go through because I think I'm a little bit behind in time. So primarily Black and Hispanic, mostly people from the South in terms of insurance. Commercial insurance was most common, about 65%, followed by Medicaid population. There are other comorbidities, obviously, so about 20% hypertension, obesity, and about 12%, lipid issues about 10%, and some diabetes as well, too. And I think we talked about the regimens in terms of dolutegravir and elvitegravir at baseline, which were then switched to mostly bictegravir and some dolutegravir, and quite a few were already on TAF. So this is a study kind of looking a little bit more contemporary regimens. So the results, we can just have you kind of focus on the right here. And so to help explain this, the integrase cohort is in the blue line on top. The darker purple line is the PI cohort. So to kind of help you through this, let's just focus on A here, which is looking at weight. The bottom one is looking at body mass index. And if you look here, this is the mean weight before starting the integrase inhibitor, okay? And even though the PI arm is here, these are people that started an integrase inhibitor, okay? Then the integrase inhibitor was started, and then you can look at the mean weight on that regimen. And so on those, and so what we saw was that maybe those in the PI cohort, once again, on integrase inhibitors, for whatever reason, these people had a little bit more weight gain initially on their integrase inhibitor. The important thing is here is that this is the time point when they switch. And what we see here is that when they switch to, so the blue line shows that this is the integrase inhibitor, switching from one integrase inhibitor to a second integrase inhibitor, maybe there's still a slight increase, at least in the slope of that line. If you look at the protease inhibitor arm, however, maybe there's just more of a flattening. So the thought is that perhaps switching to a boosted protease inhibitor regimen, maybe you can change the trajectory of the weight gain to maybe flatten it. Who knows if with time maybe that can decrease or not, but that's what that is suggesting, versus maybe the integrase inhibitor arm still is continuing to increase. And that's kind of what that is suggesting. More data here in terms of looking at what they found was that by 9 and 12 months, what they saw was that there was much more of a weight gain that was associated with integrase inhibitors in comparison to protease inhibitors. So if the bars are over to the right, it was suggestive of a higher weight or body mass increase in integrase inhibitors. I'm going to skip that. So that was the integrase inhibitor and weight gain issues. These two sections are much shorter here, but let's, for sake of time, we'll talk a little bit about hyperglycemia and diabetes. So bottom line, there's conflicting data initially. I think that was seen limited data really in regards to looking at glucose abnormalities and integrase inhibitors. There have been data from the NA Accord study showing that the incidence of diabetes compared to the general public was actually twofold greater. And those initiating INSTIs actually had a 17% greater risk of diabetes compared to those on an NNRTI. but that risk actually attenuated. And the challenge with diabetes is how much of that diabetes is related to weight gain, how much of it is really just related to the medication itself. And it's very hard to try to determine the difference. But there were other cohort studies in the WISE cohort looking at women that did not show necessarily an association with integrase inhibitor use. But more recently, there have been some cases of diabetic ketoacidosis in the literature associated with integrase inhibitors. And these are 3 cases that are actually quite compelling in regards to really this relationship from a temporal standpoint, from a time standpoint of initiating an integrase inhibitor and then seeing diabetes, diabetic ketoacidosis. And so there's one example looking at raltegravir where someone was started or switched from an efavirenz regimen to a raltegravir regimen and then had an elevated, had diabetes, diabetic ketoacidosis, and then immediately upon switching, then the A1C normalized. So it really kind of suggests it is more of a medication issue. But it is interesting with raltegravir, which is really fairly neutral, at least as we think, to see that, for instance. Second case was about dolutegravir in a similar way as well, too, in terms of hyperglycemia up to 949, A1C 3 weeks after a switch up to 15%, very dramatic, right? And then switched off, and then later on the A1Cs back to 6%. So really interesting situations. Another one with bictegravir as well. So it's worthwhile just to be aware that these do exist, and we have seen these kinds of changes. So actually, this is a study, I'm just going to kind of cut to the chase. This was a study looking at body mass index changes and looking at initiating a new antiretroviral therapy and looking at integrase inhibitors. And what was found here is here in the green bar was that people who actually gained at least 1 unit of body mass index, so 1 kilogram per meter squared, actually had higher risk of developing diabetes. And I think this gets to what Stephen was talking about in terms of when you look at weight over time, you do see that people do tend to probably gain weight over time. And how much of this is just kind of normal weight gain that even if they were not on an integrase inhibitor, you would see. And I think that is always hard to gauge. This study here was looking at another database study looking at people starting antiretroviral therapy between 2007 and 2018. And bottom line here was that people who were on integrase inhibitors were actually 31% more likely to develop diabetes and hyperglycemia compared to those without. And the highest risk was actually associated more with elvitegravir than dolutegravir than raltegravir. And you can kind of see here on the right here, these lines are on the right of the line. And so their conclusion, at least in this study, was that integrase inhibitors was associated with risk of new onset diabetes in the first 6 months. So something to keep an eye on. I'm going to just kind of move through. Yeah, 10 minutes.
Time.
5 minutes. All right. So obviously there are, in terms of cardiovascular disease, I think people remember about the DAD study. So back in 2003, suggesting a safety signal that was associated with MIs. There was then follow-up data looking at specific antiretrovirals. So indinavir, as well as lopinavir, ritonavir had increased risk of causing MIs. And then abacavir was later looked at in regards to cardiovascular risk as well too. But there have been no studies suggesting that non-nucleosides may be related to cardiovascular disease. And that's, I think, a point that I'll make again later on, is that it looks like maybe non-nukes might be something to consider if you really do have concerns about some of these metabolic issues. In terms of the etiologies, I think it's still unclear, but there are many, well, there are some theories in regards to related to lipids, related to platelet hyperreactivity, but not much is known about integrase inhibitors. For the sake of time, I'm going to actually just move on to the one I wanted to, the last two studies I think I will talk about. There was something called the RESPOND study. This was a recently published paper just last month, looking at European and Australian cohorts, over 32,000 people. Participants were followed basically to look at their first cardiovascular disease event, either a heart attack, a stroke, or other a cardiovascular procedure. There are 29,000 people included in this analysis, with a total of 748 people with HIV. I'm going to kind of cut to the chase here. So total of 748 cardiovascular disease events. Primarily, if you look at baseline characteristics, people basically had the same, the people who had heart attacks and cardiovascular outcomes had higher hypertension, diabetes, risk factors for heart disease that you might expect. But one of the things that we saw here is that looking at so there is a DAD calculator that you can use to determine what the 5-year cardiovascular disease risk is in people with HIV. And if you apply that to a population, and if they had moderate or higher risk, they were much more likely to be on an integrase inhibitors, whether these were naive individuals, whether these were experienced individuals. And that's what this is basically showing. This is probably the more interesting study. So what this is showing here is that at 6 months, there was actually an increased rate of these cardiovascular events that then kind of over time actually started to decline. So this is suggesting that within the first 6 months, people might actually be at higher risk for cardiovascular events. But then, as you see with time, that actually tends to drop. And by 24 months, their risk is back to more of a baseline. But this is kind of some of the first early data suggesting that maybe there is something here to look at. All right. And very last study, I know we're getting close. So this was also presented at IAS, looking at cardiometabolic outcomes of people starting integrase inhibitors. Another database study, and I'm just going to skip to the chase here. So when we look at, I know it's a little bit hard to see, but looking at any cardiometabolic conditions, what was found was that, so I've kind of written it here, so it's a little bit easier to see. There are about 39% in the integrase inhibitor cohort and 40%. So really no real difference that was seen here in regards to if you were looking at time from beginning to getting any cardiometabolic outcome. If you look specifically at cardiovascular outcomes, also similar between the two. And so heart disease or cardiovascular disease, or sorry, heart attacks, I guess, we're seeing about 16% CAD and about 20%, CHF and about 17%. And sorry, let me just show you this one. The bottom line of this study was that if you look, MIs and CHF was actually seen more commonly in the integrase inhibitor cohort, as well as lipid disorders were actually more common. I'm sorry about that. And they looked at a variety of other things, but in terms of looking at specific time to a cardiovascular event, they did not necessarily see specific differences, but when they actually looked at specific cardiovascular, like MIs, et cetera, there were some differences in integrase inhibitors. So sorry for kind of running through that. I was going to ask, so does that change your opinion about using integrase inhibitors? We will skip that. Bottom line, I think in terms of recommendations, I think diet certainly for everyone is important. And I did show that one study that hopefully is helpful. I think physical exercise absolutely is important, especially if we're also trying to prevent things like frailty as well too. I think if there is obesity, I think there is this, now we're seeing much more use of these GLP-1 agonists. Now there's something called tirzepatide that is actually quite useful for lowering weight even more in obesity. I do think that if there is lipodystrophy present, however, then maybe using tesamorelin still is of use. Right now, we don't know if the weight gain is related to visceral fat accumulation or subcutaneous fat accumulation at this time. And I think you can perhaps start considering switching antiretroviral therapy. I showed you the one study, but there are other studies that are going to be coming out soon that are going to be looking at these issues more in depth. But I think proactively, it's worthwhile to really start screening our patients for other things. So related to weight gain. So certainly things like hypertension, diabetes, fatty liver, for instance, and I think certainly cardiovascular disease. So I will probably just stop there and give us a few minutes to see if there are questions. I'm sorry, there's a lot of data and some technical difficulties. So Darcy has a question. I'm more than happy to repeat her question, but
I will just play devil's advocate. So I think the IAS study about switching to PIs from INSTIs or other non-INSTI meds is really interesting, but also really sad because those numbers were large and this was all done outside of clinical trials. So like very, very uncontrolled. I don't know if they said like why the medications were switched and was it always for weight gain or was it for other things? And I know when I try to avoid switching for weight gain because we don't have controlled, really high quality data. When I do, because the patient's like, I'm not going to take my medications unless we address this weight issue, I'll switch to NNRTI. So I'm interested to sort of understand why the PIs was sort of more common, but I think we have to be really cautious because it was definitely observational retrospective. And there are prospective RCTs going on that hopefully will give us some higher quality data about switching because we do know, right, INSTIs, especially second generation INSTIs are superior in some studies to virologic suppression. So just to play devil's advocate.
Completely agree with that entire point. Yeah, I think that the data quality isn't the best. We don't know why they switch. And so the challenge with a lot of these database studies is it's just data, right? You don't have no idea why things were done for whatever reason. So you're absolutely right. I think the caveat in regards to not switching willy-nilly, I think is also good. I have not been aggressive at all with switching people because I don't think we have the data. I do agree that perhaps switching to a non-nucleoside might be the safest thing if you're looking for a switch. But just like you, Darcy, I've only switched people only if they were saying they will not continue this regimen. But I do know people who do switch because they feel like maybe it helps. So, yeah.
There's a question in
Sure.
the chat. Has there been a study in people with diabetes on SGLT2 inhibitors and weight gain on integrase inhibitors and or TAF to see if they reversed weight gain?
Yeah, not,
I'm guessing not yet.
it's not in the literature, but I think there is. I know, I believe through ACTG there might be one. I think Jordan Lake might be leading that one. That perhaps, but I know that those I think are in the works, and hopefully we will get some more data in regards to that.
I was just going to say, I mean, I think your point I think the group of highest concerns are those rapid weight gainers, right? I mean, people putting on 2-3 pounds, maybe they're not happy about it, but that's probably acceptable to most. So it is really tracking those people who seem to rapidly gain. And of course, you have to think about all the confounding factors that you brought up, but those might be the people to sort of really look at and consider. The other group I was just thinking about are young people. And we have no idea what this looks like, you know, over time. I don't really think about a lot of these issues in my 20s, my 20-year-olds and 30-year-olds, but you know, is it something to think about? You know, is it when they get older, you have to think about this more, or is it something you have to really start looking at a, you know, at a younger age?
Yeah, and I think it's a good point because the studies suggest that the people that are older are actually at less risk for this. So suggesting maybe younger people may actually want to be more aggressive with looking at. But with that said, I probably am really trying to look much more closely as people get to age 40. So I'm fairly aggressive with looking at more like insulin resistance and early insulin resistance. So that includes sometimes more than just an A1C, because if you really think about an A1C is even looks at 3 months, your blood sugar over 3 months, which is really kind of a later marker. So sometimes I'm actually doing things like fasting insulin levels or trying to calculate HOMA-IRs on people just to kind of get a sense if they are on the spectrum of, and I find that insulin resistance oftentimes predates and is associated with things like weight gain, but also diabetes, et cetera. So.
Hello.
There we go.
Shannon has her hand up, and this will be the last question.
Sure. Okay.
Thank you. Great job, Dan. Just wanted to make a comment to your point about, counseling patients about diet, trying to get at this question of whether or not there's a subconscious, increase in appetite or something that's going on there. There was an interesting study at CROI, or oral abstract that was in 2020, where they tried to look at people that were initiated on ARVs and changes in resting metabolic rate and caloric intake. And they showed no changes over 6 and 12 months. It was just an observational study with a small number of patients. But, it suggests to me that, how we talk to people about this is important, right? Because they're not necessarily, even if they change nothing about their lifestyle, they're potentially going to continue to gain weight. So it's almost like they have to proactively then go on a more aggressive weight loss diet when switching to these agents, which I think makes it a little bit more challenging and potentially, I just think about what's realistic to tell people, right? Anyway, I'll link to the abstract in the chat, but it's something I kind of struggle with is, kind of warning people about that risk, but also, keeping in mind what's realistic for them.
Yeah, no, I think that's fair. I think absolutely when I talk to people about starting an integrase inhibitor, I do at least let them know that this is a possibility and that, it's something that we can watch. I think this opens up the ability for us as clinicians who to actually talk more about things like diet and exercise, and use this, as a way to kind of, to have that discussion. We probably, I know we don't have a lot of time to talk about these things, but you can always send them my way. So I'm more than happy to talk with them and meet with them and do a little bit more. So thank you. All right. Thank you. Have a good weekend.